Thank you very much. Two very relevant and insightful and helpful presentations. Thank you. I am looking at the time, and we are a little bit over, but I'm sure there are people who want to ask questions, probably have no more than 10 minutes total. So I would encourage you, if you do have questions, to please come forward to the microphones. Go ahead.
Peter Antebi. Dr. Alberts, I wanted to commend you and thank you. What we've been able to do in South Florida with respect to stroke, we must have used your name in vain many, many, many times in the papers you've written. We took a lot of shots from the CEOs of hospitals. We always ask what's best for the patient. So I wanted to thank you publicly. Thank you.
Thank you very much. Thank you.
All right, I have some questions, really for both of you. The devil's always in the detail. We are considering this possibility of forming a coalition, and there are innumerable detail-type questions. So could you both briefly tell us how you generated funding just to get off the ground initially, and then what you did to develop sustainable income thereafter?
So I'll take the second part of that first. We're still working on the sustainable funding, although the American Epilepsy Society has been really generous in providing staffing support to us. And so what we did was to initially put a sliding dues structure in place when we formed as a more formal organization, the Epilepsy Leadership Council, based on the annual budget of the organizations. And that gave us enough funds to show the American Epilepsy Society Board and our private industry partners that we were serious about working together and moving this forward, and we're now in the process of developing proposals and working to get additional funding.
So the Brain Attack Coalition, we meet under the auspices of NINDS, and they provide a lot of the support and infrastructure in terms of meeting space and staff support, which is critical. We ask the different organizations that I listed up there, we ask them to nominate or send a representative to the BAC meeting, and we meet 2 or 3 times a year on the NIH campus. So they provide transportation support, and then the rest of it just sort of happens.
All right. What about leadership? So you're both organizations of organizations. I would assume that within that list there are much larger organizations and some smaller organizations. How do you determine who drives the bus? Who leads the group?
Well, I'll start first. In the case of the BAC, we were very fortunate because the former head of the stroke program at NINDS, Dr. Mike Walker, he's retired, so he has a lot of free time on his hands, so he has volunteered to lead the BAC. So that sort of just happened, and I'm fortunate enough to be the co-chair of the BAC. And the membership, as I said, is determined by the different parent organizations. So there is a real sense of shared ownership and commitment. And as we've come up with publications and as we move the field forward, you can imagine that enthusiasm and participation has really risen. We do have new organizations that want to come in. Just say, hey, can we be a member of the BAC? So we invite a member of that organization to present to the BAC what their organization does, what their role would be, and then we vote on yay or nay for membership. We have not taken any industry sponsorship. We've had a lot of industry folks wanting to give us funds. We've decided at the BAC level to not do that. We want to remain, quote unquote, pure, and that's the path we followed forward.
And you do not have to answer this, but can you give us an idea of your budget?
You know, it's really done with NIH, and I don't have access to that, but the bottom line is it's very modest. Okay. It's very modest.
All right.
Yeah, I mean, I could guesstimate based on the number of people that come to a meeting, but yeah, I mean, that's, I think, the beauty of partnering with NIH is that you then have access to a lot of facilities and coordinating without having to really pay for it. Taxpayers are paying for it, but you're not raising funds to do that. I think for the Epilepsy Leadership Council, as I said, we elected a board, and what we did, the step before that was really to identify people and leaders within the organizations who could come together to agree on things like a charter and bylaws and those sorts of operating principles that then everyone bought into. And then once we had the nominations and the board elected, then the board elected their leaders, a chair and co-chair and treasurer. So it just kind of happened.
All right, so Vicki, it looked like your organization took approximately 1 year and 9 months to actually get their mission statement and operating procedures and fully established. Is that about right?
Yeah, it didn't seem like it took like that long, but when I put the timeline up there, I think it did take us that long. And again, it was, I think, more initially deciding on did we want to, there were many groups who thought we should become our own separate 501c3. And that was, I think, one of the biggest hurdles was making the decision as a group that we weren't ready for that.
And how often did you meet initially to get to that point?
We had lots of conference calls, not meetings face-to-face, but there was a small group of us who were meeting probably every other week to talk things through and work on different areas of the bylaws or whatever.
Right. And Mark, your organization is much more well-established, but can you recall really from thought conception to organizational structure for your organization, roughly how long that process took?
So I think a lot of that stuff occurred in the mid-1990s around the TPA time. So I would say it took them a good 3 to 4 years to properly evolve, and it's constantly evolving, but we have mission statements on our website, and as I said, we meet 2 to 3 times a year on the NIH campus.
Sure. And obviously, cardiac arrest has a huge mission, a wide spectrum, and what I heard both of you say is that it's important to focus the coalitions that you have on topics that benefit from that total coalition. Mark, can you expand on that for your organization?
Yeah, so the Brain Attack Coalition has focused on a lot of other missions, such as improving public and professional education about stroke. They've been involved in terms of educating about the NIH stroke scale score, making that a universal assessment tool. But what has really galvanized the BAC over the past 10 or 15 years has been this Stroke Center initiative, because it gave it a focus, it gave it a structure, it gave it a raison d'etre, if you will. And that's why I think that analogy is very strong for cardiac arrest centers, because it gives you some brick and mortar as opposed to just virtual reality, if you will, and it grounds it in something concrete. It's where the patients are, where the resources are, where a lot of what you do takes place. So I think that's been very helpful in terms of focus.
Lance?
Yeah. Again, thank you, Lance Becker from New York. Can you address a little bit more the process that the organizations that joined went through as they had to decide sort of, are they better off together or doing this alone? What was the value proposition, if you will, to the individual organizations, and how did they do that? Or how did the coalition help them to do that?
Well, in the setting of stroke, I think they sort of saw that this train was leaving the station. This move to establish stroke centers was leaving. So, what they say, either if you're not on the menu, then you're on the table. So, we wanted them to have a place at the table as we move forward because, again, stroke, just like cardiac arrest, is so multidisciplinary. Neuroradiology has to have a place. ACEP has to have a place. We said, we need your input. We need your expertise. How can we make this better? So there was a sense really of working together. There was a sense initially that we are not doing a good job taking care of stroke patients. This would be one step forward. We need you to participate. And the fact that they all had a voice, they all had not veto power, but they all had input into any of the major decisions. They all read the manuscript. They helped draft the manuscript. That was really the input that moved things forward.
All right.
Thank you. Juliette Saucy, EMS Medical Director. Great presentations by both. While I agree with you on the time-sensitive illness line, my question would be, how would you have seen EMS's role in this had trauma is about recognition, rapid transport, stroke, recognition, rapid transport, cardiac arrest, recognition, on-scene treatment? providing people that are survivable to go to cardiac arrest centers. So how would your interface have been had you had to weigh into the care provided, not that you don't, but very heavily into the care provided on scene, not just recognition and transport to a destination, appropriate destination?
So I see it, to borrow a term that Paul Pepe established many decades ago, really as a chain of survival. Because what happens in the field, whether it's stroke, cardiac arrest, or trauma, is obviously linked to how the patient is going to do and their outcome. Communication, resuscitation in the field, using telemedicine or a cell phone to see what's going on. I view it as just really a variation on the theme. Certainly the out-of-hospital care that they get and the care paradigms need to be established and reinforced and educated, but I don't see that as distinct. I see that as just part of the chain of survival. Maybe I'm naive about that. But that's why, again, I think having this core of cardiac arrest centers that I see as a resource that can interact with your professionals in the field and help them improve the care, I see it as again, a continuum of the care paradigm, if you will.
Thank you.
Okay, unfortunately, we're going to have to stop the questions here. We'll break for 10 minutes and start our discussions at 2 o'clock in the breakout rooms. Thank you.